So, Tony, I want to start with, I suppose, an uncomfortable question. If you had surgery today at a major teaching hospital with a fully credentialed surgeon, what's the honest answer to the question, how would you know they were actually competent to operate on you?
I mean, the bottom line is you wouldn't know. I started working in this area about 30 years ago, and the assumption was that because somebody was a consultant in a public hospital and maybe they had a private practice, it was an indication, that they were good. And then what I learned was it's actually to do with, okay, where did they do their fellowship? Where were they trained? Who did they work under? What courses did they do? And so on. But over the years, what I've learned, it means absolutely nothing. Because somebody can attend a course and they can walk away and you've no idea what they actually have learned, cognitively, or what they can actually do. And it turns out that when we assessed individuals about what they can actually do at the end of a course, we were shocked. I mean, the first few studies that we did, we thought there was something wrong with the methodology, because what we were finding was that large numbers of the trainees could do very little. They knew very little about the procedure and they could do very little safely. And then on top of that, what we started to learn in the early 2000s, when we did a study with the American College of Surgeons, where we assessed only attending consultant level laparoscopic surgeons, that we found that some of them were performing up to 20 standard deviations away from the mean in the wrong direction. And again, we questioned, we must have done something wrong. This can't be right. These are fully credentialed, hospital consultants or attendings working mostly in university teaching hospitals. But over the years, what we've learned is the methodology was sound and the results were robust. What we weren't ready for was to accept that some of the individuals working in our teaching hospitals, in our general hospitals, they're really not very good at what they do. So when you go into a hospital to have a procedure done, the credentialing, it tells you something. It tells them being through the process of that country or that hospital, but it doesn't tell you anything about the skills level. Probably the best way to find out about the skills level of the surgeon is to ask one of their colleagues who will give you an honest answer, or better still, ask the theatre sister or the nurse in charge of the operating room. They're more likely to know who they wouldn't have operating on them, their family, or their children, because there's individuals that you really don't want operating on you, your family, or your friends.
It's eye-opening. Do you think it's fair so to characterize the current model of professional training as one of the most consequential unexamined assumptions in modern institutions and modern health institutions?
Yes, I think that's completely right. We're relying on a training paradigm that was developed during the late 19th, early 20th century by William Halsted at Johns Hopkins Hospital. Halsted, my reading of him, I could be wrong, my reading of him is he was a challenging individual to work with. He had very exacting standards, and not everybody that started their surgical training with him actually completed. He learned a lot of lessons from Europe, so the probability is that he was quite authoritarian in his approach to the trainees. But the thing is that the trainees had sufficient procedure volume and supervision by Halsted or his colleagues to ensure that they had the opportunity to become a good surgeon. And if they didn't meet the skills levels that Halsted or his colleagues expected, they didn't finish. But the problem with that was it was very subjective. And today it's still very subjective. A lot of how a trainee progresses depends on the consultant that they're working with, the references that they give them, and so on. And the whole process, there are far, far too many holes in it. And for the 21st century, with the rate of change of technology, with the complexity of the technology that and it's not just surgeons, it's cardiologists, it's any of the proceduralists. The technology is changing apace, and that's going to continue. The bottom line is that we need to know what somebody can do, what they know and what they can do to some sort of performance level, because what we're 100% certain about now is that knowledge and that performance level coupled, you can't have one without the other, that's almost certainly going to impact on outcomes. It's not a one-to-one correlation, it's not a 100% predictor, but the data clearly show that if somebody's not very good or they're not very knowledgeable about the procedure or task that they're doing, they're much more likely to have a bad outcome than somebody that knows the procedure well and is quite good at it.
And given what we're measuring in training at the moment, which is time in seat, hours logged, courses completed, these are the currencies of almost every training program on earth. Why are they the wrong metrics, and what should we be measuring instead?
It's slightly worse than that, because the medicine, and particularly surgery, has cottoned on to the idea that they must measure performance. And now if you take a look at the training programs around the world, yes, there's an emphasis on procedure numbers. Yes, there's an emphasis on the variety of procedures that they do and the mix of procedures and so on. But what's also been included in the assessment is Likert type scale assessments. These were originally developed to assess attitudes to things, personality attributes and so on. They're totally unfit for assessing technical performance or cognitive performance. But this is what's being widely used, so it gives the illusion that performance is being assessed, but they're not being assessed. I mean, these are entirely subjective, and there's no training on how to use these instruments. And when we assess the use of those instruments, the correlation or the inter-rater reliability between two independent assessors, it's very weak. And if a trainee was to take a case against the hospital or the training program that assessed them, the hospital or the training program wouldn't win, because the data is very clear. These instruments do not assess performance reliably. I think a lot of the training programs that we have, the assessment programs and so on, they're smoke and mirrors. I mean, the bottom line is that around the world, we now know that when trainees finish their residency, whether it's in the United States or whether it's in the UK or Europe, they're not of the same performance level, the same skills level as consultants or attending surgeons who completed 20 odd years ago. And that's for a variety of reasons. It's not the trainee's fault, I don't think. I mean, there's reduced work hours in Europe because the assumption, well, it used to be the assumption the more hours you work, the better you are. That's not correct. In the US, there was a reduced work hours because of a fairly disastrous case in New York, Libby Zion, where the residents in charge of the case were actually blamed for it. So the residents have less opportunity to acquire their skills. In the past, there would be significantly more operating experience. Today, the technology is much more complex. The consultants and the attendings are less likely, are less enthusiastic about allowing the trainee to use the technology to operate on one of their patients. And so the trainees being pushed from different quarters. And the assumption is that training in the skills lab will substitute for the experience that they're losing in the operating room. And that's problematic as well, because trainees go to a simulation center and they talk about playing on the simulator, which I find, appalling. The simulator is a tool for facilitating or helping the trainee acquire a level of skills. But what the data clearly shows, if you don't have the performance metrics to guide the trainee through the performance, to give them explicit, constructive, formative feedback on their performance, literally they are only playing on the machine. So they need guidance. So the simulation is just a tool, whereas in medicine and in surgery in particular, it's seen some sort of magic bullet. It's not. It's a tool, and it has got to be used as a tool as part of a curriculum. And the curriculum has to come from the clinicians, the surgeons, the cardiologists, the radiologists, who actually know how to do the procedure. Not individuals who have an opinion on how to do the procedure, but individuals who are experienced in the procedure, who know the best approach for a trainee at the start of their learning curve to learn that procedure. And by and large, that's not really what's happening. There are a few exceptions, like the Arthroscopic Association in North America, like the European Robotic Urological Society. So there are a few exceptions, but by and large, simulations use it in educational experience. And the bottom line is what we're left with is trainees who are graduating as fit to be independent consultants. And when you objectively assess the performance, even on a relatively straightforward procedure, we find that the vast majority can't do the procedure safely.
So, Tony, now that you've identified the problem very well, you've also presented a solution. And your study with Neil Seymour, published in the Annals of Surgery in 2002, showed that simulator-based residents reached proficiency faster and made 60% fewer errors than their non-virtual reality trained peers. But that was over 20 years ago. why didn't that finding transform surgical training overnight?
To some extent it did. I mean, the paper that you talk about, we did in 2000 at Yale, the Department of Surgery in Yale, and it was the American Surgical Association education paper in their April 2002 meeting. It was published in Annals in October of that year, and it was a citation classic by Christmas. And the surgical community were looking for some sort of solution to the problem of reduced work hours and reduced procedure volume for the trainees. Virtual reality simulation seemed to be ideal. But it had been around, Satava had first talked about it in the late 1980s, early 1990s, so it had been around for over a decade, and nothing really had happened. And what the surgical community wanted was robust evidence demonstrating that simulation produced a better training outcome, and we provided that. The American College of Surgeons took that on board. Jerry Healy led a meeting in, I think, April or March in Boston College, and the question was, what position should American College of Surgeons take towards simulation-based training? And at the start of the meeting, they basically said, well, we need a clinical trial. And I piped up and said, okay, we're going to present it at the American Surgical Association. This is what the results suggest. Jerry Healy is an interesting man. He worked at Boston College. He was a pediatric surgeon. And Jerry could be quite a tough character. And I'm not sure that he was top of everybody's popularity list, but he was a good leader. Jerry listened to what was said, and he turned the meeting on its head. And then rather than asking, should the American College of Surgeons, what position should they take in terms about simulation-based training, he said, how should the American College of Surgeons adopt and implement simulation-based training? Which, I mean, I thought Jerry showed true leadership that day. And the rest of the meeting rolled in behind him. Okay, there were awkward questions and so on, but basically they got it. And they knew that if we were presenting at the American Surgical Association, the study was good and the data were sound. So in 2006, the American College of Surgeons established the accredited educational institutes. And all of them were to establish some sort of accredited simulation centres. These were evaluated in terms of the types of surgery and surgeons who were going to teach or being taught on it, the instrumentation, the space, and all the rest of that. And it's quite a rigorous process. But the problem is they have something like over 100 of these centres in the US and around the world. They're all accredited. And they're all doing different things. And they're all using simulation as an educational experience. They're all using Likert scales and so on. And that really shouldn't have been the function of...
But Tony, does that not show then that you're finding in that paper and with all the research that you've done both then and since that it hasn't transformed surgical training to the overwhelming extent that you want? I appreciate it's a citation classic, and I appreciate that with leaders like Jerry, as you mentioned, things can be pushed forward, but eventually there's a regression to the mean, a regression to the status quo.
Yeah, I mean, it has I mean, for example, if the American College of Surgeons decided today to use an outcome-based approach to training, they have everything in place. What they have not done is insisted on a standard, the establishment of performance metrics, the establishment of proficiency. I mean, they have all the pieces in place, but that last, and so, I mean, a lot of it's really like smoke and mirrors. Yes, the trainees enjoy it. Yes, the faculty enjoy it. Yes, the facility looks fabulous and all the rest of it. But when you assess the trainees when they come out at the end of the training, I mean, which they don't, but when we do, what we find is they can't do very much. And we know now for certain, since 2015, having simulation facilities, no matter how good they are, having those facilities available, have trainees go through, it means almost nothing. You know, it's an interesting educational experience. And we know that from the Arthroscopic Association of North America. We completed a prospective randomized and blinded study of something like 20-odd trainees from 20-odd ACGME approved orthopedic residency programs in the United States. And they all come into Chicago for a simulation-based training course. One group got what they would normally get today. And I've got to say, Anna prides itself on doing good training. So the first group that got, by any measure, what Anna would consider good training. The second group got the Anna training, plus they had simulation. And group 3 got what Anna would normally give, plus proficiency-based progression simulation. So all three of them shared the same fundamental elements, which was the Anna curriculum. Group 2 got simulation added to that, and group 3 had simulation, but they had to demonstrate proficiency benchmarks the whole way through. And what we found was that the simulation, the Anna trained group did worse. And I think Anna was kind of shocked by that. The group that had simulation added to their training, the assumption was it was going to have some sort of marked impact. It didn't. I think 5 or 6% more of the trainees demonstrated the benchmark. Whereas the proficiency-based progression trained group, 75% demonstrated the benchmark. And I mean, the results were quite clear. Having a good curriculum, having fabulous facilities, and adding simulation to it means almost nothing in terms of the training outcomes. It's the metrics used to deliver a curriculum on the simulation that actually makes the difference.
That's a well-articulated exposition of the problems with current training. But then we ally that to the issue we're going to uncover, hopefully, with the next question, which is there's a cultural assumption that experience equals competence. That when you have a seniority, that grey hair means experience, effectively. So what does the evidence that you've gathered actually say about that?
Yeah, I know. I started out with that assumption 30 years ago, and I would, when I was going to assess a surgeon or video record the performance, I would ask him, okay, do you know how to do this task? Yes. Okay. Have you done it before? Yeah. And how many times have you done it before? Because I assumed that the last two almost certainly were going to impact on their performance. I now ask another question. Show me. Because what I find is the correlation between the first three questions and the last question means absolutely nothing. I mean, somebody can have a large amount of procedure volume experience, and you would think that they're learning during that. A lot of them don't. The mistakes that they were making, or the errors that they were making, at the start of their procedure experience, they're still making it today. Now, that's not the case for all of the surgeons. I think the majority, I wouldn't say the vast majority, I would say the majority actually do learn from their experience. Experience is not a bad thing, and it's correlated. It absolutely is correlated in the past with procedure outcomes, with skill. But the problem is the correlation is so noisy, you have no idea what you're getting. And it was used as a surrogate for the performance or the operating skill of the surgeon. And what we found is there's actually a better way to establish the skill level of the surgeon. And that's objectively assess their intraoperative performance on a straightforward case, not a complex case. Because the complex case can throw you so many curveballs. A straightforward procedure that the surgeon or the cardiologist or the radiologist should know how to perform, has done frequently. You record that, you objectively assess it with their metrics. That'll tell you more about their skill level than their procedure volume. And one of the shocking things that we find is the trainees, I don't mind, the trainees are still fixable. And as you would understand, there's different performance levels that trainees are at. That's fine, they're still in the training. And once you identify these issues, you can fix that. But if you have a consultant or an attending out in independent clinical practice, and you find that they're performing, not only are they performing significantly worse than some of their colleagues, their consultant colleagues, they're performing significantly worse than some of the residents in training, that's a significant issue. The first time we found that, we probably didn't believe it. For example, the study that we did at the American College of Surgeons in 2001, and that was published in the Journal of the American College of Surgeons in 2003, we were shown that some of the consultants were performing particularly badly. To be honest, in 2001, we thought that we did something wrong. We set out to establish what's the correlation between doing a task on a virtual reality simulator and doing the exact same task in a box trainer. That's what the college asked us to address. The most important finding to come out of that study was some of the consultants really weren't performing very well. And we have now replicated that across procedures, across disciplines. And what we're finding is some of the consultants that are actually in clinical practice, when we objectively assess their performance, from their video recorded clinical performance, we find that some of them do very, very poorly indeed, and indeed some of them are unsafe.
Now that we've identified the problem, we'll get to the solution, and the solution that I've mentioned in many talks as being the single most impactful methodology I've come across in my career as an instructional designer. So, Tony, to proficiency-based progression. Can walk us through the mechanics. What does a proficiency-based progression curriculum look like? What are the errors, metrics, critical and sentient errors? Can you explain the methodology to us?
Proficiency-based progression, one of the reasons I developed a scientific approach to training was there was so much in surgical training, surgical appraisal, surgical assessment that was subjective, that I thought it was unfair on the trainee or the consultant who was being assessed. So I approached it with a more scientific eye. And one of the big issues in the late 1990s, early 2000s was how do you establish a benchmark for a procedure? And to me, it seemed obvious. You establish the benchmark on the surgeons who are actually good at the procedure, and that's what we did at Yale. But to do that, you've first of all got to develop the metrics. And one of the things I learned fairly early on is that you have individuals who have lots of opinions about how to do a procedure. And when you check with colleagues that you know that are pretty good at what they do, they don't necessarily agree with that approach. So one of the first things about proficiency-based progression is establishing the metrics. What I do is I get 3 to 5 clinicians who are good at the procedure, not necessarily world leaders, but individuals who you'd be happy operating on you, your child, or your partner, or your family. I get those 3 individuals or 5 individuals together, and we work through a straightforward or reference approach to the performance of the procedure. This is a procedure that the trainee should be able to do at the start of their learning curve. And we assume there's going to be no complications. We assume it's being done on a straightforward patient. And we work out what are the phases of the procedure, the chunks of the procedure. And within each phase, what are the procedure steps and instruments that the trainee must use to achieve that phase. And then, most importantly, what was new to training was we established deviations from optimal performance. Okay, we're looking at a trainee or somebody doing the procedure, and they do something, you go, probably shouldn't have done that. Now, we call that an error, and it's a deviation from optimal performance. Medicine and surgery have difficulty conceptualizing that because they consider errors critical errors, and that is something that you see a consultant or a trainee doing, and you're going, what the hell are you doing? It's something that's going to compromise patient safety or the safe completion of the procedure. So those are your building blocks for the procedure or for proficiency-based progression. You have the steps of you have the phases, you've got the procedure, you break it up into chunks or phases. You then have the steps, the errors, which are deviations from optimal performance, and the critical errors, which actually compromise the procedure or patient safety. Then you've got to validate. Because, I mean, those just might be the opinion of 3 surgeons who were there on the day. And so, one, you've got to then get consensus from their peers, not agreement, consensus. Okay, that may not be the way I would do the procedure, but it's not wrong. Then you would take them to construct validity, do the metrics. 1, can you observe them? 2, can you score them reliably? And then 3, do the metrics distinguish between the objectively assessed performance of experienced and novice operators? And by and large, I mean, I have yet to see a study where they don't discriminate. And once you have construct validity, then you've got your proficiency benchmark. Because the proficiency benchmark is based on the mean score of the experienced practitioners. How many errors did they make? Because every procedure has errors. I mean, even the best surgeon in the world is going to make some errors and possibly some critical errors. So how many steps must they complete? Under how many errors and critical errors? So there you've got your proficiency benchmark. The metrics also point you towards what simulation you should use. Unfortunately, that's not the way it is today. People build a simulator and then they go looking and say, okay, this simulator will fit this procedure or that task. That's not the way it should be done at all. You first of all need your metrics. The construct validity will give you your benchmark, but it will also tell you which parts of the procedure the trainee finds most challenging. And okay, you want something that's going to simulate the entire procedure, but you also want something that's going to allow the trainee to hone their skills for that particular task or phase. And so part-task trainers are very useful here. And if you develop your simulation from the metrics, the validated metrics, you're on a sure winner. Because everyone thinks that the simulator, it's got to be pretty, it's got to be full physics, virtual reality. That's not the case. So once you've got your metrics, you've either built or decided what simulator that you're going to use, you then train your faculty on the metrics. Because they have to be able, one, they have to know the metrics. Two, they've got to be able to give the trainee explicit, constructive, formative feedback using the metrics on their performance. And what we find is this accelerates learning enormously. Because the trainee also has to know the metrics. Before they turn up to the course, they preferably have to learn the metrics, usually from online. We know that given the trainees, the information in the lectures really doesn't work. There's a study published by Stefano Pugliati in the British Journal of Urology fairly recently. And what it shows is that trainees who got the metric-based information in a lecture took 100% longer to reach the proficiency benchmark than the proficiency-based progression trained group who got the information online. So the trainees, they would turn up to the course knowing the metrics. They would have to pass at a proficiency benchmark on the online part of it, again established on the mean of the consultant's performance. They would then progress into the skills lab. They would be supervised and trained by a faculty who could be a fellow, who knows the metrics and is able to give them explicit, constructive, formative feedback. And they continue training until they demonstrate the benchmark. Doesn't matter whether they take 2 hours, 2 days, 2 weeks, 2 months, doesn't matter. They must demonstrate the proficiency benchmarks before they progress to clinical practice. And what we see when we do that is that trainees perform on average about 60% better in the operating room. The systematic review and meta-analysis published by us in 2020 shows that trainees who go through a proficiency-based progression training program make 60%, on average, 60% fewer objectively assessed intraoperative errors than trainees trained on a quality-assured traditional approach to training.
And key to that approach, Tony, and you've mentioned it already, is the idea of deliberate practice. So it speaks to the primacy of feedback and the training of the trainer and why that's so important to PBP. It was certainly something that stood out to me when I've seen the in-person training and the kind of feedback that the fellows or the trainers are giving to the trainees. Can you just briefly expound on how important that is to PBP and how that differs, how deliberate practice differs from repeated practice in your mind?
Yeah, I mean, but if you go back, you've got to go back a bit. One of the things I noticed when I was doing trainings in the late 1990s, early 2000s, is if you went from training station to training station, the feedback that the trainee and the style of the trainer was very different from consultant to consultant, and it wasn't the skill level of the trainee. And Erickson developed the idea of deliberate practice a few decades ago. And he talked about learning music or high-skilled performance. And he talked about deliberate practice. And he wasn't as explicit as I would have liked him to be about deliberate practice. But what he meant, what he actually said was that trainees learn faster if you give them constructive, explicit, detailed performance on what they were doing right and what they were doing wrong. If you transpose that onto medicine, we need the metrics to be able to do that. Yeah. And you need a trainer that knows the metrics, but you also need a trainee that knows the metrics. When a music student is playing the wrong note, they can hear that, so they can. The trainee who's learning to perform a procedure, a surgical procedure, they may not know it. Whereas if you ensure that they actually know the information, in an online curriculum, before they turn up to the skills lab, they're going to recognize it. And what it means is, in the past, in a training lab, the trainees did the task over and over again, and hopefully they got it. Frequently they didn't. And on top of that, we never assessed the performance. Today, what happens is we give the trainee explicit, constructive, formative feedback in a timely fashion, proximate to, when they actually did something wrong. Or even, you might even say to them, are you sure you want to do that? For example, if they were applying staples at an angle rather than perpendicular or to the longitudinal axis of the colon, you would say that, are you sure you want to do that? And they'd say, well, what do you mean? And you would point out, is that an error or a critical error in the metrics? And it's amazing how quickly they actually get it. I mean, what you have to remember is that the trainees, these are bright individuals, they're committed, and they will learn very quickly. One of the issues, Frank Lewis, who was the chairman of the American Board of Surgery when I worked in the US, we would go for a beer after meetings. He said, Tony says, I like this idea of proficiency-based progression. He says, but I have two concerns about it. Number one, if you're setting the benchmark on the consultants, he said, or the attendings, that's going to be far too high. He said, we set the benchmark today on minimum competence. And the other concern that he had was, how long is it going to take to get somebody to the proficiency benchmark? And to be honest with you, those two questions remained unanswered until, a few years ago, and have only recently been published.
Mm-hmm. Those questions were also very much part of the program approval process that we had to undertake in University College Cork, where there was always the question as to why your proficiency benchmark or passing scores were so significantly higher than what would have been the departmental norm or the university norm, which would be arbitrarily set at 60 or 70%. So you've spoken extensively and written extensively, Tony, about simulation. And it gets a lot of attention in medical education, the shiny new thing, or sometimes a solution looking for a problem. But what's missing when you put someone into a simulator without the proficiency framework around it?
The simulators are more developed now as a marketing tool rather than a genuine training tool. And the reason is that, well, I think one of the reasons is that they're more for marketing, is that the manufacturers tend to be the purchasers, the biggest purchasers of virtual reality, physics-based virtual reality simulation, number one. And so they want something that's a marketing tool. Number two, it's expensive to develop the metrics, and it's even more expensive to build it into the virtual reality simulation. And a lot of medicine doesn't realize that. They think it's just like a video game and you just tell it, oh, you need to measure this, measure that. And that's not the way it works. If you're talking about highly sophisticated physics-based and simulations that are derived from mathematics and engineering solutions. So this takes time. But what we find time and time again, if you don't have the metrics in a simulation, really what you've got is an educational experience. Now, if you don't have the metrics in a simulation and the simulation is good enough, if you have somebody standing beside the trainee who knows the metrics, they can use that simulation as a tool for the delivery of a metric-based curriculum. And that's, to a large extent, that's what we're actually doing today. We're supplementing what the simulation should be doing. And I think part of the problem is that I said industry was the largest purchaser. That shouldn't be the case. It should be the health care service organizations, such as the Department of Health around the world, that are purchasing simulations on large scale for all of their teaching hospitals. They or the training bodies should then say what the curriculum is, what the metrics are, what the benchmarks are, and so on. That's not what we find. I mean, frequently when I go to training centres around Europe, that we see simulations, and some of them are in the box. They haven't even been taken out of the box. And we're talking like a few years after they've been purchased. And some of them that were taken out of the box and they were used for a photo shoot or a television appearance, they're getting duffed. Yeah. I mean, there are so many reasons for it. I mean, it's a change. You've got to learn how to use it. You've got to learn the metrics. You've got to learn how to use the metrics. You've got to develop the metrics. You've got to benchmarks. You've got to validation. And it's easier just to use something like Likert type scales, which give generalized qualitative feedback to the trainee. And it's unfair on the trainee. And I think that it slows down their skill development. Well, I know it slows down their skill development and the way that they go about learning procedures.
That speaks to an earlier question in terms of why the methodology hasn't been adopted widely is that it's pushing against that status quo, which reverts to that more experiential type of learning.
Yeah, that's right. I was in Australia. I was in Melbourne at the Society of Robotic Surgery. I was giving a keynote, and somebody from the audience asked me, "Okay, Tony, if you've all this evidence, why hasn't it been adopted by now?" And I hadn't thought about it until on that moment, and the words were out before I'd actually realised I was thinking it. It's a failure of leadership. The reason that the Arthroscopic Association of North America, that European Robotic Urological Society, that the RC Academy, the reason that they're using this methodology is leadership. From the top down, whether it was Rick Angelo, Dr. Rick Angelo, Professor Alberto Breda, or Professor Alex Ma, they said, this is what we're doing. I want the metrics for this. I want the benchmarks. Tony, tell me what simulations we need. What do you need to... The reason it's happening in these organizations is it came from the top.
But would it be not the case, Tony, though, that it will never receive widespread adoption if it's always reliant on leaders like Alberto Breda, Alex Motry, and Rick Angelo? It'll need something more, and rather than just better leaders, it's either medicine will eventually have to adopt this because insurance companies or other stakeholders in healthcare will oblige them to do so.
Yeah, but I think you've got to start with leadership. And I think what each one of those leaders are doing, they have juniors coming along behind them that basically are 100% convinced about this approach to training. But you're quite right. I mean, I was having a conversation with one of my former fellows who is a manager for Medtronic and training. And he said, Tony, this is not about evidence. He said, there's sufficient evidence out there that shows that by any stretch of the imagination, whether you're talking about training effectiveness, whether you're talking about training outcomes, it doesn't really matter. The evidence is there to basically show proficiency-based progression is a superior approach to training, and that it's inevitable that medicine will have to adopt it. And each argument that has been raised to say, well, we can't really do proficiency-based progression because we're not going to get everybody to proficiency. It's going to be too hard to develop the metrics and so on. These have been shown to be inaccurate. The benchmarks are too high. And one of the last and I think most significant pieces of evidence comes from Stefano Pugliati. And his study was looking at, okay, can we train everybody to proficiency? But he also looked at what does it cost? Because one of the biggest arguments was that the metrics were too expensive to develop. And what Stefano's data shows, if you're only going to train 12 trainees, the proficiency-based progression approach to training is 100% more expensive than the conventional approach to training. Okay, the conventional approach to training, you only get 58% to proficiency, whereas the PBP approach, you get 100%. Well, let's ignore that. What he also looked at, what happens if you roll it out to, say, the size of the US or maybe Medtronic training? And, if you're doing 500 trainees a year, what he found was that it costs about 1.7 million to train 500 trainees to proficiency using the PBP approach. It costs 3.5 million to train the same number of trainees using the conventional approach. One of the things that I really didn't expect from that, so I thought that we would have to train like 100 or 150 before we would have cost equivalence between the metric development, the cost of the metric development and the training. That's not what he found. The cost equivalence point was 25 trainees. That sort of data is very hard to ignore. And the medical device manufacturers are looking at this quite closely because they have new devices coming out all the time. And there's a significant proportion of their devices that fail in the marketplace. And they get the device back to the manufacturing plant and they dismantle it and they take a look, was there something wrong with the device? There wasn't anything wrong with the device. This is particularly the case for the CRT or the pacing devices. And they've always suspected, but they couldn't really say publicly, well, we think it's probably the clinician is the reason that the device failed. The data is now there. The assessment methodology is now there to say conclusively, yes, this was a device issue, or no, this was a clinician issue. And all of that means that it's uncomfortable for medicine because we can now, rather than just subjectively say that somebody's not particularly good at what they do, we now know that if somebody's not particularly good at what they do, it almost certainly is going to impact on patient outcomes. Because one of the big issues that I've run into over the years is individuals in leadership, in medicine and surgery say, okay, Tony, you've got this fabulous methodology, but it makes no impact. It makes no difference really on patient outcomes. The data now is 100% clear. A study published in 2013 in the New England Journal of Medicine by John Birkmeyer. What he looked at was attending level laparoscopic gastric bypass procedures. That is, none of these procedures were done by residents. All of them were highly experienced laparoscopic bariatric surgeons. He video recorded their performance. He had them blindly assessed as to who was who and what level they were at. And they banded the surgeons into 4 levels, those that were not performing particularly good, 2 middle quartiles, and a group that were performing particularly well. And what he found was he followed up all of the patients those surgeons operated on over a period of 6 years. And what he looked at was, okay, what are the outcomes for the patients of those surgeons? Not surprisingly, what he found was the surgeons who were assessed at the outset of the study as performing best had significantly better patient outcomes. To be quite frank with you, that wasn't really the surprise. The surprise was the magnitude of the difference. The smallest difference between the surgeons who were performing well and the surgeons who were performing badly was 50-odd%. Patients who were operated on by the surgeon who was pretty good had a 50% plus lower reoperation rate. The highest difference was 81% in terms of mortality. Mortality rate was low in the study, but the difference was still 81%, and it was statistically significant. To be frank with you, that was a shock to me. I was working with George Shorten, who was the Dean of Medicine in Cork at the time, and we were having a discussion in the boardroom one day, and George said, yeah, I know, Tony, proficiency-based progression produces, 60, 70, 80% better skills levels in trainees in comparison to He says, but a lot of that's going to wash out in clinical practice. And to be quite frank with you, I believed him. I felt that too. The data now shows that that's not the case. And we also have evidence that proficiency-based progression, simulation training, the impacts on patient clinical outcomes to the magnitude of about 60%. In one of the studies where trainees were trained on a proficiency-based progression training program to perform an epidural for women that were having a baby, we saw a 50+% difference in epidural failure rate for trainees who didn't have the PBP training. So we know that the training, it's not going to be 5 or 10% difference. We know that the outcomes are going to be of the magnitude of about 60%. These sorts of findings is going to make it very difficult for medicine and surgery to retain the line that they're currently retaining, which is non-adoption.
And it moves past the surgeon too, doesn't it? I mean, PBP has now been implemented for communication skills in Cork University Hospital and increasingly been used to train entire teams in a surgical context or in, say, wound care or patient management post-operation as well.
Yeah. I mean, I don't know. I don't know that I was surprised at the findings, because basically the underpinnings of proficiency-based progression are very simple. You take somebody that's good at the task, not world class, but somebody that's good at the task, they get into work, 8 till 6 every day. They're good at what they do. They're diligent. They attend to detail. They make mistakes. They recognize them. They fix them. You take that individual and you work out what is it they do, what is it they're good at, at what sort of performance level, and you work out, okay, what are the units, what are the metrics, what are the steps, what are the errors, what are the critical errors, and you can apply that to anything. We applied it with Dorothy Breen at Cork University Hospital to a communication skill. And lo and behold, guess what we found? That trainees who were trained using a proficiency-based progression training program performed about 60% better than trainees who'd gone through the national training program. In Ireland, the Health Service Executive have a national training program for the handover of a deteriorating patient. And before you go clinically, it doesn't matter who you are, you've got to pass this training course. So all the trainees who turned up to our all of them had passed that already. And when we assessed the trainees who turned up, who had already passed the national competency communication for the handover of material, when we assessed them, none of them demonstrated the proficiency benchmark. So you start with something relatively simple. You start with somebody that's good at it, work out what they do, what they don't do, benchmark on those individuals, build a curriculum around those metrics, and the outcome is pretty certain each time. You're going to see at least a 60% improvement in performance.
And it's moved out of the medical and surgical space as well. And that case study that we collaborated on with Reach Active as well, in terms of the procedures and processes that they characterize as well, and the results were similarly striking there, were they not?
Yeah, my brother's owned a fairly successful utilities company. And he had read, I don't know why he had read my book, but he had read my book. And he said, I think you have a solution to a problem that we have. And so we talked. He's an accountant. Seamus trained as an accountant. And during the summers, when he wasn't at university, he used to work on the roads, putting utilities into the ground. And on one occasion, he put a jackhammer that he was working on straight through an electric cable, a high voltage electric cable, and it blew him across the road. And Seamus is quite a bright guy, and as a company CEO, he knew that this was working in the utility sector. This was a risk for his workers. And in Ireland and in the UK, what we see is that there are a number of deaths and very serious injuries from striking, usually an electric cable, but could be a water or a gas cable. And so he asked me to develop a proficiency-based progression training program for the identification of the utilities in the ground, and then being able to safely excavate those utilities. So we went through the same program. We took some of their workers who were experienced and good at the job. We developed the metrics. We validated them. We set a benchmark. They built a simulation yard. They took a part of their space. They put utilities into the ground, and they could switch those utilities on and off. And the trainees had to go through an online didactic course, which I think you built. And they had to pass that before they got to the simulation space. Now, remember, what we're talking about here is non-university people. These are youngish fellas, labourers who are basically digging out the roads and so on. So these are not university graduates. They're not medical trainees. And we found the exact same thing in the utility sector as we found in medicine. The trainees who went through a proficiency-based progression training program, at the end of 1 year, Reach Active were saving over €1 million a year in utility strikes that they avoided. So it works across the board, but you always start with the same process. You'd start with an individual or individuals who are actually good at the task.
And it's a very important message, and it's one I think that anyone who's listening to this and who's runs a training program should pay heed to. And speaking to that particular audience, and if people are running their own training program, everything from vocational training to something like teacher education, and they want to move towards proficiency-based progression, Tony, what's the first question do you think they should ask about their current curriculum?
Who's good at the task? Because you need to identify those individuals. And it can't be just because they're your buddy, or it can't be just because you like them, or it can't just be because they're senior. You need to identify individuals who are good at doing the task that you want to develop a proficiency-based progression training program. Then you're going to have to learn how to do that. You're going to have to either go back to you're either going to have to talk to me or somebody like me. You're going to have to go back to my papers or the book, and you're going to have to work out the methodology. I mean, and one of the things that we're seeing is, or I'm seeing, is individuals who think they know how to use the methodology, and then they ask you, well, what do you think of that? And you're going, might have been better if you'd done this, that, or the other. I was at a Delphi, and I was there as an observer at a Delphi meeting in Miami a few years back. They developed the metrics for a colorectal procedure, and they hadn't developed the metrics for a colorectal procedure. They were still developing them during the Delphi, and they asked me at the end of the meeting, "How do you think that went, Tony?" And I said, "What do you have?" And they had nothing. I mean, they had added to the metrics, but I mean, they had no idea whether the metrics were actually going to stand up to more robust assessment. Needless to say, the metrics They weren't. They didn't go anywhere. I've never seen them published. I've never heard of them being used. That meeting cost over $100,000. I mean, I'm from Northern Ireland, and we would consider that a bit of a waste of money. I mean, I like to see what's coming out at the end of it. It's like if somebody's going to do a procedure on me or my family or a friend, I want to know, okay, are they any good? At what level are they? And I don't need them to be expert, but I do need them to be able to do the procedure, and I do need them to be able to do the procedure safely.
Sure. So you need to find, in your particular industry, for the task that you're looking to train, you need to find people who are objectively good at doing that task.
Yes.
And start with them.
Yes. Yeah. And have a reasonable attitude. You don't want somebody that you need to do therapy on whilst you're trying to develop the metrics. I mean, it's individuals.
Someone who's collegiate and collaborative.
Yes. But I might put it more robustly. After all, I am a psychologist. I mean, it's just too much like hard work. It's like pulling teeth.
I suppose it's an issue across medicine. It's an issue across every industry. There's a tension between time in training and time where they need to perform their task or they need to deliver their service, be that in medicine or be that in any industry. So how do you make the case for PBP to a department head or to an employer who says, I don't have the time or the faculty for this?
That's the wrong attitude. They have to, if they're in the business of training, they're financed and they're funded for training. And the trainees can't just be used for the delivery of service. If they don't want to do training, get out of that business. But if they're in the business of doing training, they need to go and look at Stefano Pogliatti's data. Basically, what it says, number one, you can train somebody faster and more cost effectively using PBP than you can, with a traditional approach. But what they also must look at is the Berkmeyer data. It's unequivocal. Individuals who are not trained properly, who are not benchmarked properly, they are going to have more bad outcomes, patient outcomes, than individuals who are trained properly, who are skilled and knowledgeable about the task that they're supposed to do. And I mean, the hospitals in the United States, I think that's starting to change. I mean, somebody said to me when I worked there that a lot of the hospitals and healthcare organizations made their profit on the complications that the clinicians, were that caused or involved with. That's changing. The Centre for Medicare Services is now saying, okay, what's the complication rate, the average complication rate for that procedure? Okay, 5%, 7%, whatever. We'll allow that and a bit of wiggle room. You see anything more than that, the hospital has to eat the cost. Until that sort of approach is introduced more en masse, I'm not too sure there's an incentive there. For example, the manufacturers, I said earlier about a lot of the devices fail, and it's nothing to do with the device. If the device is explanted and another one is implanted, the manufacturer gets paid for that device. So there's no incentive there. There has to be some sort of incentive. But I would hope that the organizations that are involved with training are of sufficient integrity and professionalism that they take their commitment seriously. Trainees, yes, they deliver service, but the onus is on the organization to train them. And when we go around the world, what we see is that onus or that training delivery varies very considerably. I have a lot of Italian PhD fellows, and some of the stories that I hear are quite horrendous in terms of the training that those individuals get. I mean, there was a guy who applied. I was the head of the laparoscopic center in Emory in Atlanta. I was the director of research and training, and we had one Italian guy that applied. The chairman of surgery sent over his application. He said, this guy's finished his residency and he's applied, for residency here, and we think he's made a mistake. He was obviously applying for one of the laparoscopic fellowship. So anyway, we got the guy in and we interviewed him. He said, no. He said, I was applying for residency. I've completed my residency in Italy. He said, but I can't operate. And I mean, he couldn't do the residency. Yeah, that's why he applied for the residency rather than the fellowship.
That brings us right back to the very first question. How do you know that someone is qualified to do the task that they want to operate?
Yeah, but a trainee is a trainee, and I don't have an issue with that. You mean it's only once the day that they're independently licensed, then I have an issue. I think that there should be no should be no tricks. There should be no hidden agenda in it. The idea is to have people good at what they do, knowing what to do and how to do it. We need some sort of a verification, because at the minute somebody qualifies, and the assessments that they get post-qualification are, shall we say, less than robust. They're mostly didactic. There's maybe a portfolio of procedures that have already happened, already been done. What we need is some sort of an assessment of the intraoperative performance of the clinician on a straightforward patient. Because clinicians, I mean, cases can go. I'm not saying that all clinicians are really not skilled or not up to. I'm not saying that at all. And every clinician can have a case that just goes particularly badly through no fault of that surgeon. But if you pick a straightforward case that went straightforward, and that case is assessed, I don't see what the surgical community or the medical community have to be concerned about. We have no robust verification of the performance levels of our clinicians. This is not just the procedure-based medicine individuals are going to be relatively straightforward. I mean, because we can see what they do and we can ask them about it. The internal medicine clinicians, I think that's going to be more challenging. But it's not an issue. Behavior is behavior. If they do something or say something, we can assess that. Was that correct? Was it inappropriate? And we're not looking to catch anybody out. Catholic University Leuven in Belgium's introducing a proficiency-based progression training program into the robotics training program and across residency. And I was given a lecture or a half-day session, and I was given one of the keynote lectures. And a lady who was head of training, she stands up and she said, hold a second, Professor Gallagher. Are you telling me that you tell the residents what to do online and you assess them on that and they can do it as many times as they want to pass it? Are you saying you tell them what to do, you make sure that they know it before they turn up for training? Then in training, you allow them to do the task, or you supervise them doing the task. You assess them on the same metrics. You give them feedback on what they did, and they can do that as many times, but they still have to demonstrate the benchmark. She said, so you're basically telling them what what the assessment is, and then you're telling them, what they did wrong so they can fix. And I said, yes. She said, that's not the way we do it. She couldn't get it. She couldn't get the tricks in this here. The idea is to help the trainee to get to the performance level. Anything that we have to do to get the simulations and the curriculum are really just there to help them. We've invested, the kids have invested so much of their time and their effort getting into medicine. The onus is on us to make sure that they can be a good clinician, they can be a good doctor. And there's no tricks in that. If they know how to do a straightforward procedure and they're interested enough and talented enough, they'll learn to do more complex stuff. If they don't know how to do a straightforward procedure or perform it safely, they're a risk. They're a risk to patients.
So proficiency-based progression, we're respecting the trainees' time, we're respecting the trainers' time, and we're also respecting their future patients.
Yes, that's right.
Training them with the most robust methodology we can now.
Yeah, I mean, it's a scientific approach to training. It's objective. It's transparent. It's fair. I mean, the benchmark.
Repeatable is key.
Yeah. I mean, there's no tricks on this idea, where an examiner gives you these random questions of this curveball case that they saw 30 years. No, that's not acceptable. All that tells you is about the examiner. I mean, I want to know, do they know the basics? Can they do the basics? And I certainly don't want them to be doing it at a competency level. I mean, I thought I understood, when we say competency, we mean minimum competency. And I would hear that now and again, and nobody says minimum competency. And when I started reading about competency, and I'm going, minimum, and this is what we're training to. And I'm going, oh no, that's not acceptable, not procedure-based medicine, too high risk. And proficiency, I mean, the question, Frank Lewis, can we train everybody to proficiency? Yes. In every procedure, probably not. You probably don't want them in every, but we can train the absolute vast majority to proficiency. And I think the outcome of that approach to training. It's certainly better for the trainee, because I have a fellow, he's now a consultant in independent practice. He said that when he learned proficiency-based progression, the metrics, I was training him to do the assessments initially. He said it changed his approach to learning a new procedure, and it changed his approach to how he trains others. Because here you have a structured, objective, explicit, transparent, and fair approach to training. I mean, there's no curveball, there's no hidden agenda here. And even if a consultant doesn't like a trainee, they can only assess what they objectively see, their performance. They can't assess, I don't like this individual.
So, Tony, to wrap up, so 30 years from now, when someone is writing the history of how professional training finally caught up with what we know about human performance, what do you want the chapter to say about this period and about the work that you've done?
Well, I hope it clearly shows that, number one, that it works. I mean, I'm not too sure. I mean, I've been working at this now for like 30 years. And somebody said to me once, Tony, why are you still doing this? And I said, because I'm stubborn. I mean, if something's right, and you know that it's right, and you've got the evidence that it's right, and it's so hugely impactful, why would you not continue? I'm not sure that'll be talked about. And I'd be happy enough if, number one, the approach had been adopted, and number two, it had permeated into other aspects of training or performance even. And medicine is going to become more robotic. That's 100% certain. Artificial intelligence, so long as the bubble doesn't burst too bad, I think it will eventually become an integral part of simulation-based training and proficiency-based progression training. But artificial intelligence, everybody tells me about, okay, we're going to be able to assess performance, and, we'll be able to... No, they won't. Because artificial intelligence, first of all, needs to be able to assess the metric. How far an instrument travels, how efficiently the instrument travels. To be quite frank with you, it's a measure of process. I mean, like, if I'm going from here to Dublin, I can go... If all you're assessing is, okay, Tony drove to Dublin from Belfast to Dublin, it doesn't tell you how many car accidents I had, how many times I broke the speed limit, the number of pedestrians that I either hit or nearly hit. Measures of process are insufficient for effective training. And that's what AI does at the moment. It needs to be able to assess the granular performance of the surgeon. Okay, was a linear stapler, was it perpendicular to the longitudinal axis of the colon before it was closed? How many staples did they have? The suturing, how was the suture driven through the tissue? Did it tear tissue on the way through? Were the sutures equally? It's not able to do that at the minute. I absolutely think it will be, but not at the minute. And we're going to need huge training data sets.
Of properly performed surgeries to the benchmark to train that. Yeah.
And I think that the AI will probably be introduced first into the endovascular spheres, because the endovascular virtual reality simulators, the physics-based virtual, they're the best on the market. They're the most expensive, but they're the best on the market. The surgical simulators have a long, long way to come yet. But I mean, I'm still a huge fan of virtual reality simulation. I think that's part of the future. But medicine must see simulation as a tool. Artificial intelligence needs to be seen as a tool. The clinician at the end of the day has to make the judgment. The metrics of optimal and suboptimal performance has to come from the clinician. And I think what we're going to do is proficiency-based progression and the methodology, the scientific methodology that underpins it, and the validation evidence means that the direction of travel is inevitable. And I think it's going to take somebody in a leadership to say this is happening, whether it's in government, whether it's in the scientific societies. I mean, I don't know.
Well, we'll watch this space with interest, Tony, and continue to impact it with more papers and publications. Yeah. Thanks for your time, sir.
Thanks, Patrick.